The topic of this lecture is female inmates and mental health and their mental health needs. So, female mental health needs have to be specialized. There's what we call vulnerable or subpopulations. Females are a very small portion relative to males of our correctional system. So, for example, in the state prison system I'm familiar with, there's about 28 prisons, and two of them are female and 26 are for the men. Um, we do know they have specialized mental health needs that are often different from the males. And we also recognize that prisons in general were not designed to deal with these special health needs. We can see with South Carolina, um, in 2009, it cost $16,000 per year per inmate. That rate now is about 26,000. So about every 10 years, you could add about another $10,000 to the cost per inmate per year, or $1,000 per inmate per year to these numbers to calculate how much it costs. Or you can actually go to most websites for prisons and jails, and they will actually identify how much they pay for mental health, physical health, housing, etc., food for inmates. So some of the specialized services that relate to female inmates that are different, and obviously ones that can impact mental health and outcomes, is pregnant inmates, OBGYN services. This can also include screening tests for cervical cancer and other gynecological physical health considerations. Females, in terms of crime, disproportionately will be found in certain types of crimes, such as cycles of prostitution and drug abuse. And so histories of these types of crimes and behaviors require specialized interventions. Female inmates may have long periods of dysfunctional relationships that need to be factored in. And there's some controversy. There's voices for and voices against this notion, but with the use of females in gangs, there seems to be a subset of female inmates who are displaying more violence in general than they have in the past. So if we look at the numbers in our state prison systems, about 2/3 or 66% of all female inmates have a diagnosable mental health condition. I would say of the remaining 1/3, there is a group that you would say is under mental distress, maybe not a diagnosable condition, but certainly a vulnerability. 2/3 of all female inmates are actually mothers to children. And so in terms of things like jail visitation and visitation policies, this becomes an important issue. The men will also have visitation, but there seems to be a linkage with female inmates where relationships and relationships to the children are highly impactful in terms of how female inmates serve their sentence, whether they engage in programs, whether they have better outcomes for reentry, visitation, and the role of children to mothers is a very important topic. Before incarceration, the vast majority of these female inmates actually lived with their children. That's not always the case with the male inmates. And so there's this connection in terms of inter-family relationships that becomes a specialized consideration for female inmates. And there's a great deal of information that these mothers have more than one child, so they're often the foundation of the family, and so the children may be placed in foster care, or perhaps a family member like a grandparent is looking after them, and this can add considerable stress to the mothers who are incarcerated. We also have to consider for physical health and mental health that there is a subset of females who, when they're incarcerated, are pregnant. So we have to think about issues here about how the pregnancy occurs. Obviously, once the woman is ready to give birth, they're taken out of the prison, and there's been some historical examples where, while they were giving birth, they've been handcuffed or shackled to the bed, and so we have the intersection there of the criminal justice system with the health system, and we have to think about what the best outcomes are for these inmates and their children after they have them. So once again, females represent a fairly small part of the total inmate population. However, they do require specialized or different services. We could say the same thing about other groups such as LGBTI as a vulnerable population and juveniles. So there's quite a few subsets, and it's simply a matter of adjusting our approaches in physical and mental health to best serve them. In general, in terms of mental health, female inmates are much more likely to discuss with others their own emotional well-being or their emotional or mood state. They're also more likely to engage in counseling, whether it's group counseling or one-on-one, and they're also more likely to take medications if it's recommended. So female inmates are a much more active and more compliant population, whereas the male subculture in prison often stresses do your own time. That is, don't complain, don't talk to anyone, do your own time. And so there seems to be a gender type of role that takes place in terms of the way people, men and women, respond to mental health symptoms and how they seek treatment and how they react and externalize these behaviors. We know in general that because of this, female inmates are much more vocal in terms of getting together as an inmate group, expressing dissatisfaction to staff and to the warden, and males are much more individualistic in the way that they serve their incarceration time. The mix of early trauma, victimization, depression, and substance abuse is often similar in both genders. The numbers may be a little bit different, but there usually is a constellation or a mixing of all of these type of risk factors. Once again, the way that it is experienced by the male or the female inmate tends to be a little bit different, and the institutional responses or the responses from the prison are different. Another reason that contributes to these differences is that prisons originally were not well thought out. The history of prisons often involved finding a cave or a abandoned warehouse and placing men, women, and children all together. This led to a lot of abuse and trauma. It also led to a lot of disease and problems because they were not managed well. Over time, policy is directed towards obviously having male institutions, female institutions, and juvenile institutions. However, there's been a slow development in programs that we call gender responsive programs. That is, programs that recognize the important differences in gender and capitalize on what these differences are. So one form of gender responsive programs examines the pathways towards offending and ultimately to incarceration. So men and women generally, though not always, but generally have different pathways towards the crimes, their involvement in crime, the subculture, whether it be a gang or a group of deviant peers. They have different pathways towards that criminality, and they also have different ways that they engage in incarceration. One thing that female inmates will do that you will not see in male prisons is females will create what they call quasi-families, and this may involve some lesbian relationships between couples, but it also extends into interpersonal and family relationships where other inmates will be called auntie, uncle, cousin, dad, mum, etc. They are all female inmates, but they identify roles and create a family of sorts while incarcerated. The role to, or the pathway to incarceration for females often includes some sort of dysfunctional relationship and or drug use. Not all the time, but there tends to be some overlap in terms of relationships and the use of drugs in relationships that you may not see in the case of men. So continuing to do functions of programming, education, policy in general should consider the role of gender in these things, and it is an important consideration for correction administrators and staff. Thank you.